يلا يا جماعة ركزوا معنا. No side talks. Your phones silent. Switch your phones off or put them in silent, please. Okay. So the physical examination for the respiratory system starts from the first look. While the patient, you are taking history from the patient. You can notice if he is using his accessory muscles, if he is in distress, and if he is cyanosis or something like that. So the physical exam starts as soon as you start talking to the patient. But when you need to do proper physical examination, first, the exposure for the patient should be around 45 degrees semi-sitting position, and the exposure anything above the umbilicus. Okay, so above umbilicus and above. Sometimes for social reason you might expect to do that below the breast nipples, the breast line. Okay, should be supported with a pillow as well. We start systematically always the examination in general. Wherever you do examination, abdominal, respiratory, cardiac, you start with inspection, palpation, percussion, and auscultation. This is the hierarchy and this is the order that should be followed always. Okay. First thing in the inspection, as I said, the patient environment while you are talking to the patient. Is he in distress? Is he using accessory muscles? Like what? Accessory respiratory muscles? Intercostal muscle is an accessory muscle. Diaphragm accessory muscle. Sternocleidomastoid, trapezius, platysma, these are the pectoralis major, these are the accessory muscles. Okay, intercostals normally صديقي لازم يتحركوا. شو بصير فيهم intercostals in order to breathe? Contraction, what will do? Outward and downward. يعني بمعنى آخر it increases the space allowed for the lungs to expand in order to fill the pressure. Along with the diaphragm, there is a contraction. But the contraction of the diaphragm is unnoticeable. However, if you notice that contraction diaphragm along with the other muscles, it means that the patient is in distress. And you notice as well if he is on oxygen. Nasal cannulas, face mask, nasal bronze, anything like that, okay? Nebulizers. It gives you a hint what's going on with the patient. خاصة إن أنت رايح المستشفى تأخذ history منه. You don't know what's the case, but you will have some clues. This patient is getting his nasal bronze along with a nebulizer mask. فبتعرف إنه he's taking nebulization. And you might give either he is admitted as an asthma exacerbation, COPD exacerbation, or different things that he might have airway disease or airway bronchospasm. That's why nebulizers has been added. Okay, inhalers as well. If the patient, the bedside couch and the inhalers تعاونه ممكن تعرف كمان might be admitted for another reason, but this is home medication. فممكن you might have a clue about what's going on or what's his past medical history or what's his comorbidities. Okay. Along with the cannulas and his way of sitting in the bed. If the patient is lying supine in the bed comfortable and he's not in distress, that means that he's not in distress. But if he's sitting and he's putting a pillows and he cannot lie down, this might give you a clue probably as well. Is it heart failure? Is it tripod? Sometimes we see it more in the pediatric age. Tripod position. حدا بيعرف tripod position? Where we see it? Where? طيب شو بكون Okay, what's the underlying disease? شو no medical term, underlying disorder. ايش؟ نب ابيجلوسايتس حدا سمع فيها؟ اوكي ان شاء الله بس تروح البداياتك على البدايات rotation then you will hear about that. So it's using the tripod position. بقعد زي هيك بحط ايده ورا ظهره بيستخدم one of his hands to support his back. تلاقيه ما بيقدر he cannot lie back. Okay, أنا بصير بيكون مشكلة في upper airways. Okay. But sometimes as well, the positioning might give you a clue what's going on. Patient cannot نايم على 3 pillows or قاعد, you think about orthopnea and heart failure. Okay, patient في tripod position as well can give you a clue. Okay. Then you come from the end of the bed and you will comment on the respiratory movement and the shape. So first thing we comment while you are from the end of the bed is the respiratory rate. What's the normal respiratory rate, you know? 12 to 20. 12 to 15 is a no. But when you consider that he is tachypnic, more than 15, right? So it's 12 to 20, but you consider that the patient is tachypnic or he is aware of his breathing after 15. Good? Why is that important? يعني ليش respiratory rate مهم؟ طبعا هو بهمنا في أمور كثيرة بس why this sometimes we give a cut off numbers ليش ما نقول يعني خلاص anything above 20 or 30 or something like that. Respiratory rate is an important indicator in something called CARB, CURB 65, which is a score for the community. Yes, community acquired pneumonia. So we use it. This is a bedside, a simple tool that you can please put your phones off. You can use it as a simple tool, bedside tool, to assess the severity and to assess as well the prognosis and to decide where to admit the patient. So a simple tool. So if you have confusion, C stands for confusion, and you have to do mini-mental test, mini-mental neuro test, which is about the memory. Anything below 8 is significant, okay? Urea, anything above 7 millimole per liter is significant. It's considered positive. 1. You give 1 for each one of these, okay? Respiratory rate above 30, okay? B stands for blood pressure, systolic below 90 or diastolic below 60, okay? And age of 65. 0 to 1 mild, you can treat in the community, and the prognosis is very good. Moderate 2 is moderate, you have to admit to the ward. 3 and above severe, and often need to be admitted to the ICU with frequent monitoring, and the prognosis regarding the 30 days mortality is higher compared to the other two groups. Okay. So respiratory movement is important as well. Normally, the chest will expand during inspiration and expiration شو راح يصير؟ Expansion راح يرجع. But if there is any abnormalities, for example, normally it will move outward زي ما حكينا and downward. تمام? But if the patient is having a long-standing childhood asthma that wasn't treated, or a COPD, in the long run, especially the emphysema patient, COPD, in the long run there will be hyperinflation in both, للأمانة. Okay? But in the childhood asthma, why the childhood asthma pre-pubertal age, the pre-pubertal bone can be formed. So recurrent obstructions, recurrent air trapping, recurrent happen and hyperinflation will change the chest shape. The diaphragm will be more flattened. And the chest will be like a parallel chest. The parallel chest, usually we use it for the COPD, the emphysema in adulthood. However, نشوفها إذا كان في عندنا childhood asthma, the air trapping and hyperinflation area. This would change the shape of the intercostal and the rib cage predominantly. ليش؟ لأن the pre-pubertal bone can بعد لسه not well calcified and still there is cartilages that can grow. Okay. So the respiratory movement differs. For diaphragmatic weakness, instead of downward and outward, there will be a paradoxical movement of the diaphragm, a paradoxical movement of the abdomen. هتشوفوا إنه instead of expansion, one of the sides, حسب الsides is affected, either both sides. Either both sides, sometimes you cannot notice, لأن both sides they are not expanding well, فبتفكرها normally, and this is an effortful breathing, يعني مش ماخذ نفس كويس. Okay. لكن إذا كانت affecting one side, there will be paradoxical movement, inward movement على عكس outward. الريب كيج راح يجي لجوا راح يدخل and diaphragm trying to compensate. فبدل بسبب هذا الضعف it will be لأنه diaphragm elevated. The right side or the left side or the affected side, let's say, will have an inward and upward movement على عكس outward downward movement. احنا دائما هي contraction outward downward movement مشان تعطينا space allowed to the lungs to expand. لكن لما يكون عندنا diaphragmatic weakness or if we have for example massive pulmonary effusion or massive or pneumothorax, sensing pneumothorax at that side, which means انه راح either less expansion or no expansion, and the paradoxical movement is passive pneumonic. To be honest, and the physical examination you can elicit that might give you a clue of the respiratory muscle weakness, mainly the central parts of the diaphragm. Good. So احيانا بصير عندهم something called blatipnea. This is a bonus. شو الفرق بين الأورثوبنيا والبلاتيبنيا؟ Anyone knows? Orthopnea and blatipnea. مظبوط. Orthopnea cannot sleep. Once he sleep flat, only once he is flat, let's say, he will be suffocating. ليش؟ لأنه بصير في back pressure from the heart بسبب الهارت failure and accumulation of fluid. Good. لكن بلاتيبنيا العكس. He cannot sit down. He cannot sitting بالضايق sitting بس برتاح when he is lying flat. تمام؟ ارتاح when he is lying flat. على العكس بلاتيبنيا. Okay. This is a sign غالبا أحيانا paradoxical بتكون في respiratory muscle weakness وكمان بنشوفها كمان وين؟ pulmonary ايش؟ لا. When there is a shunting, hepatopulmonary syndrome أحيانا يكون عندنا بلاتيبنيا. And the mechanism is slightly different here. It's almost the same outcome. Okay. Good. So shape زي ما حكينا parallel chest shape يعني ال AB diameters is the same. دائما احنا ال lateral diameter is larger than the anterior posterior diameter. However, if the both diameters, the lateral and anterior posterior diameters, they are almost equal, this is parallel زي البرميل. نشوفه في hyperinflation, long-standing childhood asthma, emphysema, that's true. COPD, all of these the long-standing or chronic conditions can cause that. زي ما حكينا الendrowing of the intercostal muscle and use of the accessory muscles as well. Chest deformities مهمة. What pectus excavatum, pectus carneatum, excavatum from its name cavity. Excavatum no, بالعكس احفظوها من cavity cavitum. Cavatum يعني كهف يعني معناها يعني تجويف. فضوه هي cavatum لجوا carneatum لبرا. Okay. تمام. Cavatum excavatum most of the time congenital. It's congenital always يعني غالبا. And carneatum can be acquired. تمام. Carneatum as well uncontrolled childhood asthma زي ما حكينا لأنه بصير عندنا increase في ال AB diameter and there will be outward bulging of the sternum and the cartilaginous part of the ribs. Okay. Scoliosis, kyphosis. Who knows what means scoliosis? Sure. In English. No. Do you remember? لا مش lateral. Yeah. Scoliosis. Do you remember the curvature? بمعنى آخر شو؟ excessive curvature. احنا normally it's like 4. لا lordosis غير. lordosis في الميد لاين بنشوفها في اللمبر normally. حتى في الأطفال بكون عندهم excessive lordosis. زي like 4 in Arabic السباين تاعنا. Okay. When فاحنا في عندنا scoliosis which is curvy line concave shape من جهة الثوراسيك. When it's much more excessive يعني more than the normal هذا curvy line أو الانحناء, this is scoliosis. So normally we have scoliosis in our thoracic spine. زي الأربعة تخيلوها. اوكي الأربعة هاي ما لازم تكون اكسسيف، فإذا كانت more than that this is scoliosis. ها؟ pardon we kyphoscoliosis. sorry you are right. السكوليوسيس lateral. مين حكى lateral؟ yes you are right. فالسكوليوسيس هي lateral خبطت الموضوع. sorry for that. So the scoliosis is the lateral deviation. The lateral deviation of the spine. إنه في ميلان from the midline. Imagine if you draw a midline from the spine, then the vertebrae will be deviated either to the left or to the right. في عندنا طاجة فيهم. Okay. لكن الكايفوسيس this is اللي هي increased excessive curvature of the normal curvy line in the thoracic spine. تمام. إذا كانت في اللمبر يعني for the anteriorly this is will be excessive lordosis اللي كنت أحكي عنه. So we usually lordosis أحيانا نشوفوها بالأطفال، نشوف ماشي هيك بس with time بعدله. Okay. Respiratory rate for inspection as well حكينا عنه. Counting the respiratory rate is important for 1 minute. عشان يعني we will if it's within normal it will be different from those who are tachypneic or more than 15. That's quite important. As well skin abnormalities from the end of the bed and from when you go to the right of the bed as well. From the end of the bed if there is any skin abnormalities like ممكن rash, spider nevis. وين نشوف السبايدر nevis؟ mainly where you see مظبوط. the distribution I mean لا السبايدر نيفاي distribution في chest صحيح بس distribution related to ايش؟ superior vena cava above than the umbilicus غالبا. okay sometimes. مين كمان؟ okay so spider nevis normally how many spider nevis up to what we accept up to 5. أكثر من هيك مش نعتبرهم إيش pathological. هم basically عبارة عن إيش؟ هيمنجيومز صغار. يعني malformation شوي في الجسم هيمنجيومز صغار. في liver cirrhosis we see them in different things, but usually they follow the pattern of the superior vena cava يعني distribution which is the upper chest mainly نشوفهم. تمام؟ Good. What also? Scars like what? ثواني بس. بس في مريض تعبان. اوكي سكارز. شو السكارز اللي نهتم فيها؟ وات؟ ها؟ mid sternotomy which reflects open heart مش ضروري كبد. infraclavicular شو what does it reflect؟ pacemakers. That's good. شو كمان؟ trauma. good idea. other كمان شو كمان؟ يعني axillary scar what does it reflect؟ biopsy scar ممكن بس شيء more as we will talk about that دكتور. chest tube biopsy lobectomy pneumonectomy. Excellent. So scars, horizontal scars, it depends. يعني from the back mid-axilla زي ما حكيت أو to the back might reflect pneumonectomy, previous pneumonectomy or lobectomy. You don't know. ممكن نشوف sometimes 3 points of scars, tiny scars, 1 cm, 1 cm. Reflects that videoscopic assisted thoracoscopy, laparoscope. ليش؟ واحد why؟ واحد one for the camera one for the gas, and when they do, they put a CO2 gas as well, and for the trocar or the channel, for example, if they want to introduce a biopsy, a forceps, or something like that. So often it's 3, but sometimes nowadays it's done as many invasive procedures, single port. It's called single port procedure. صاروا يعملوها حتى يعمل لمنكتوميز ولبكتوميز, which is an advancement للأمان. Just single port 2 centimeter. بدخل منها الكاميرا, بدخل منها كل شيء. Good. Next. So you can see the pictures here, and then this is, what's this picture? First one on the left. What do you think? Hyperinflation. ليش? Anterior posterior, and he looks due to the COPD. Anterior posterior diameter is increased like a parallel chest. تمام? And the intercostal muscles you can notice as well. They are inward drawn. تحسهم زي مسحوبين لجوا and delineated, يعني مكانك ترسم خط عليه. Okay. This is always there. اللي جنبها kyphoscoliosis. And you can notice that there is a skin changes. شو هم؟ شو هاي الكبيرة؟ طب هذول صغار نيفايز مظبوط، بس أي نيفاي كبيرة؟ هم النيفايز عبارة عن هيمنجيومز هذول ولا لا؟ إيش؟ Do you think that's a spinous bifida? I don't think so. I think this is a nevi, okay? أو hemangioma, skin hemangioma صغيرة. All of these, they are nevais, okay? Good. So, but the main point is kyphoscoliosis. To the right. Excavatum. Good. To the left. Carneatum. غالبا هو سببها غالبا انه childhood asthma he got. And he got his in his left arm. شو في عنده؟ هذا رجل. سكار غالبا ما احنا عارفين شو هو، بس هي قلت سكار like a flag زي ما كأنه حدا مخيطها. Good. Then, so you start in the respiratory exam. First look. في عندنا شيء اسمه first look. زي ما حكينا نشوف is he in distress, is he cyanose, is he. You start often from the respiratory exam from the hands, even the cardiac, even the liver, whatever. You start from the hands, then you go upward to the face. Then you go to the system or to the area involved in the heel chest, either anterior or posterior. For the heart, you go to the pericardium, okay? So we do that always the same almost. For the abdomen is the same. تمام دائما هيك احنا نمشي systematic. Start from the hands because most of the time, most of the systems they get, if they have diseases, they get reflected in the hands and the face, okay? So the hands, شو بهمنا في hands? First, finger clubbing. شو هي finger clubbing? Yes, so loss of the angle between the nail bed and the nail, okay? اللي هي شامث ايش بسموها؟ When we do that. This is the first stage. Then second stage is fluctuation. Third stage اللي بسموها Japanese drum. عمركم شفتوا تبعت قرع الطبل كيف بكون من الستيك تاع الجابانيز drum بكون مضخمة كثير. This is called Japanese drum. Not just loss of the angle. بصير عندك حتى أنت الانجل بصير بدل acute صارت منفرجة مش عارف أحكي لكم بالإنجليزي بتصير الانجل كثير منفرجة. Okay, so that's the difference. So and what's the underlying cause of finger clubbing? Asthma? No, not asthma. Fibrosis. Chronic type of what? Hypoxia and sometimes CO2 retention. You are right. COPD. No. So asthma COPD does not cause clubbing. And if a patient is a COPD or he got clubbing, think about cancer. Huh? No. Liver, you are right. عشان تحفظوها في جدول في McLeod. You have thoracic, extra thoracic. The thoracic, what we have heart and lungs, okay? بس بدي اياكم تكونوا حافظين. يعني almost everything can affect. Bronchiectasis, cystic fibrosis, شو؟ chronic bronchitis. chronic bronchitis ما بتسويش كثير. Okay, the COPD does not cause. COPD, asthma, sarcoid does not cause, بس خلنا نوضح لكم does not cause ايش clubbing. And if COPD your patient developed clubbing, انت بتعرفه مريض تابعك بالعياده وعنده COPD وجدت انه صار بعد كم من سنه صار عنده clubbing, think about different underlying. Either he got bronchiectasis or he got lung cancer. Think يعني COPD per se does not cause that, okay? Though it's chronic form of hypoxia, but that does not cause, okay? Pulmonary hypertension. Sometimes it causes, yes. It depends. إذا كان في AV malformation, pulmonary hypertension, you're right. Atrial myxomas. Okay, so thoracic, extrathoracic. Extrathoracic حكيت انت liver. شو كمان؟ Crohn's, IBD, inflammatory bowel syndrome, Crohn's and ulcerative, celiac disease, excellent. Endocarditis, infected, excellent. Cystic fibrosis, bronchiectasis. So there is a plenty of causes, to be honest. But the thing that you need to memorize, asthma, COPD, and sarcoidosis does not cause. Okay? And if it's caused, think about malignancy, خاصة في COPD. The village sarcoidosis, both three of them, that does not cause. Unlikely to be associated. And if they are associated, think about concomitant pathology. Okay? يعني إشي معهم ثاني. Hypertrophic pulmonary osteoarthropathy, mainly this is a paraneoplastic syndrome, which means the neoplasm in area and the symptoms in any other area, mostly associated with lung cancer. Most of the time, or especially squamous cell carcinomas. So بصير عندنا osteoclastic activity mainly for wrists and ankles. So there will be growth. And when you do growth, and this growth will cause pain. Pain, it will be painful and tender, and بصير في overgrowth. And it's often when you do an X-ray, hand X-ray or ankle X-ray, you will see a subperiosteal reactions, which means there is an active bone formation and lysis. Active bone formation and lysis, but the bone formation شوية inactivity is more. Cyanosis. What's the definition of cyanosis? Quickly. No. When the patient gets cyanosed. موجود في McLeod. إذن when the deoxygenated hemoglobin is 50 gram per liter and above, or 5 gram per deciliter and above. تمام. We have central and peripheral. تمام. We have central and peripheral. The peripheral most of the time due to vasoconstriction, hyperperfusion state, okay, cold, Raynaud phenomena. هذول الناس اللي عندهم Raynaud, they get easily vasoconstricted peripherally when they are in cold or stress, or they are working in a vibration machine, something like that. Good. Central cyanosis. Central cyanosis almost always due to hypoxia or hypoxemia as well. Hypoxia, which is reflected by the hypoxemia. So in severe cases, in severe central cyanosis, sometimes we see peripheral cyanosis. So it's not always the case إنه يعني إذا عندنا central لازم نشوف peripheral والعكس صحيح. Peripheral mass can be localized, can be part of central peripheral, okay? And this is quite important, you should raise. Methemoglobinemia, does it cause? At first, do you know what's methemoglobinemia? Yes, excellent. So it's oxidization or changing from the ferrous, which is the reduced state, to ferric, which is the oxidized state, +3. And what does that mean? Well, how it will be reflected? Come. Yes. You mean, come. What will happen to the oxygen dissociation curve? That's true, to the left. So it will be shifted to the left, and the binding affinity to the O2 increased, so it won't release the O2 at the level of the cells. Tamam? When you put a pulse oximeter regular pulse oximeter conventional في المستشفيات وفي الطوارئ, the patient will be desat or will be hypoxic by the 70s. Then you decide to do an ABG, arterial blood gases, but when you measure it, the BO2 is normal. Anyone knows why? يعني أنت عندك البلس oximeter مظبوط, احنا حكينا هذا الموضوع, and it shift to the left to increase the affinity of the O2, and it won't release the O2 easily unless there's something, شو أجمعه, and if there's something comes that the hemoglobin loves more and have more affinity in order to release the O2. Why is that? Basically نرجع لموضوع البلس oximetry وال ABGs, because the conventional pulse oximetry they detect 2 waves, but for that you need something called co-oximetry. Co-oximetry that detects 3 waves. 3 waves. Methemoglobinemia rarely it causes central cyanosis unless the level of the hemoglobin above 15 or 20% in the blood to start to have symptoms. So it can start earlier, 5 to 10, dizziness, shortness of breath, feeling giddy, something like that. However, when it starts more than 15 or 20%, the patient might experience pre-syncope or syncopal attacks. Above 30 is lethal, fatal. Okay. Tar stains, احنا ما بنشوف tobacco stains, احنا بنشوف tar stains للناس المدخنين الاصفر على their fingers. المسل wasting بتهمنا كمان for those who have high expenditures, or if they have as well liver diseases بيكون عندهم hypothenor wasting كمان as well. So it reflects what's going on, the condition, the nutritional status of the patient as well. Yellow nail syndrome, from its name, they have yellow nails, pleural effusions, and they have lymphatic duct obstructions. Sometimes more to malignancies, might be secondary or might be primary syndrome. Secondary often lymphomas, اللي بيسكروا لك lymphatic ducts, and this is quite important. And the pleural effusion sometimes might be chylothorax associated with this syndrome, اللي هو بيكون فيه triglyceride عالي. Fine tremor and coarse tremor. Fine tremor, where we see the fine tremor? Huh? High dose, but yeah, yes. So ventolin, beta agonist, yes. Come on. Where is the fine tremor also seen? So ventolin, beta agonist, short acting or long acting, high dose, جماعة اللي بوقت البخاخات في الأزمة كثير. شو كمان؟ aminophylline بيعمل. What all? Respiratory failure تعمل لك إياها fine ولا coarse? Fine. I'm talking about, yes, course. So just talking about the fine. Where is also the fine? Thyrotoxicosis. مرضى بتحط how sometimes you put a paper to ask them to extend their hands, and you put a paper تشوفهم هيك برجورة fine tremor, thyrotoxicosis. Coarse flapping tremor حكيتي انت respiratory failure. What also? Parkinson is coarse. Parkinson coarse. Rigid cook wheel rigidity, and it's coarse. If it's yes, when you see it, it's coarse. The tremor, it's not fine. Okay. The course as well, and Parkinson is part of the course. Liver failure, anything that causes CO2 retention, heart failure, heart failure, respiratory failure, anything that causes CO2 retention will cause flapping tremor. And you ask the patient either to extend his hand, both hands, and you just notice for 5 to 10, 15 seconds if he starts flapping, he cannot maintain the posture, or شو ممكن تسأل البيشنت تقول له اعمل لك ايش؟ No. خلينا في الفلابنج. You put the index and the middle finger وتحكي له امسك لي اياهم. تمام؟ He cannot maintain the posture for 10 seconds into 15 seconds. Okay. Good. What is this? Clubbing. What we can see إنه first عندنا تقريبا this is stage 3 almost, إنه loss of the angle between the nail bed and the nail. عندنا الصورة اللي على اليمين هون جماعة في عندنا زي drumstick appearance fluctuation, بصير في accumulation of the first. It's due to hypoxia most of the time ولا لا؟ بصير عندنا vasodilation في الارتريولز, then extravasation with time this will be called something called liquefaction, يعني due to يعني أو lymphedema. I wouldn't say lymphedema on the fingers, but something like that. And a chronic fluid in the interstitium chronically there, it will lead to later on it will lead to tissue proliferation, and this will lead to increase in the size of the finger, and we will reach an irreversible stage. So stage 1, stage 2 clubbing often reversible, but 3 it's irreversible. Okay, good. Again, the Shamroth window, which is the angle, when it's lost, this is stage 1. Okay, when it's lost, stage 1. When there's a fluctuation is something you elicit. You تمسك fingers and you feel that there is a fluctuation, there is more fluid. Still, it's not liquefied. ما تحول لشيء صلب. هذا الإديمة within the interstitial space or the tissues. And on the right, what is this hand? Rheumatoid hand. Good. What you can see here? شوف شايفين rheumatoid nodules, sausage shape, مظبوط. sausage shape, laxation, بتحسها lax الهاند, subluxation. ولو انه كمان ورجينيا راح تشوفوها ممكن في شيء اسمه Z deformity in the finger, in the thumb, sorry. And maybe he have something called boutonniere, like pressing in the button, كأنك تضغط على button المصعد, boutonniere, and swan neck زي ركبة البجعة, okay, from its name, you like that, or boutonniere, when there is a laxation in the metacarpal here, okay. So this is a rheumatoid hand. So hand is quite important, okay, جماعة. And why is that important? أنا ممكن يكون عنده rheumatoid زي ما حكينا امبارح يكون عنده إيش؟ lung fibrosis, rheumatoid nodules, pleural effusion. So a lot of systems are reflected in the RS, okay, and the lungs. Face, quickly, what you can see, pale, conjunctiva. Look at the conjunctiva. When you look at the conjunctiva, you just lower it down, and you ask the patient to look upward. If you want to look for jaundice, what you will ask the patient? The upper eyelid, and you ask him to look down in order to see the sclera. Okay, so the jaundice is looked for the sclera, Jama. So this is easy to do. Ptosis with meiosis. What's ptosis? Drop of the upper eyelid, مظبوط. And when drop of the upper eyelid, and so you can see the upper border of the iris. تمام. Meiosis, constriction, Horner syndrome, which is a syndrome that occurs. Yes, what will happen? Excellent. Paraganglions, brachial plexus, and other ganglions due to the Bacchus tumor, abscess, cancer that occurs in the lung abscess, invasion of the sympathetic chain. What will cause? It will cause ipsilateral معناته على نفس الجهة, ipsilateral anhydrosis. So the area of the face will lose sweating ability, so cleggy dry, half of it. Ptosis, drop of the eyelid, and meiosis. Ipsilateral anhydrosis, ptosis, and meiosis. This is Horner syndrome, mostly to Bacchus or lung abscess tumor due to sympathetic chain or sympathetic canal chain. Okay. Central cyanosis, حكينا عنهم اللبس والtongues. You ask the patient to stick his tongue in the top of his mouth, and you see the mucous membranes below the tongue. Stick your tongue to the floor of the mouth or to the roof of the mouth. Superior vena cava obstruction. What will you see? GVB raised or sometimes not pulsatile. Facial swelling, flushing. Come on. Dilated veins. Yes, it's facial swelling in general. That's true. And puffy eyes, high lumor. Very good. Facial swelling, non-pulsatile, and the veins, superior vena cava veins, should see the collaterals, so show the collaterals. Or the distribution of the superior vena cava as well. Neck, tremor, due to what? It happens, but superior vena cava obstruction. These are the main signs to look for while, but it can happen. غالبا associated with other disease. So as you can see, this patient is having a lot of collaterals distribution, which means in the superior vena cava, غالبا this is chronically obstructed superior vena cava. فالacute obstruction بيجيك بacute presentation. بس chronic obstruction it takes a time, so there is a time, plenty of time, for the collaterals to form. Okay, so this is more a chronic issue. الصورة اللي على اليمين, which eye is affected? Okay. Are you sure? Yes. Good. Neck. Jugular vein distension. شو بدنا نحكي عن jugular vein distension. GVB is raised. How you measure the GVB? From the sternal angle, you draw an imaginary line, perpendicular, then another perpendicular line from the where you can see the GVB pulsation. This line, if it's 4, for example, إنه 4 plus 5 اللي هم إيش? The pressure from the right atrial, this is mean 9. What's the normal GVB, by the way, sorry? 7 and less. Good. Tracheal deviation, how would you look for the tracheal deviation يا جماعة? Tracheal deviation, there is 2 techniques. لا, an exam. Yes, 3-finger technique or 1-finger technique. So either a 3-finger technique, excellent, but you put the middle finger and it's normally deviated slightly to the right due to the heart, or ممكن single finger technique. Good. Deviated away, if it's deviated away, يعني في حالات الإكس-راي أو في الإكزام, if it's deviated, إحنا normally it should be deviated to the right. If it's deviated away, يعني to the other side, شو بكون الكوز؟ Or massive pleural effusion. Good. If it's deviated toward the area culprit area, so ideally we do an X-ray with that, so مشان to know what's going on. فإذا كان في عندك انت collapse, you will see that it's pulled toward to the area of the collapse or fibrosis or lipectomy. Wherever there is a volume loss, massive volume loss, it will be pulled toward it. Collapse due to mucus plug, due to foreign body, due to cancer, endobronchially, and collapse لهذيك اللوب, it will, and loss of volume, it will pull the trachea toward that side. Okay. Cricosternal distance اللي هم بسموه الايش؟ tracheal tuck, usually between the cricoid and the sternum and the sternal angle, the sternum. Ideally 3 fingers and above. If it's less than that, which means the lungs they are hyperinflated. Okay, it's quite useful in emphysema. The tracheal tug, systolic movement of the trachea in aortic aneurysm, and the systolic movement in aortic aneurysm, especially the aneurysm is above 4.5 or 5 centimeter, the dilatation. So when there is a pulsation from the heart, the trachea might move because the pulse is augmented due to the aneurysm. The aneurysm it will affect the trachea. Okay. Lymph nodes enlargement in neck. طبعا neck system, ما بعرف if you have taken it or not. We have anterior, posterior, deep, and superficial neck lymph nodes. Usually, often we start from submandibular, submental, mandibular, periauricular, posterior auricular, occipital, go down like that. احفظوا زي هيك. يعني إن شاء الله اليوم زملائنا في السيشن راح يورجوكم كيف راح يعملوها. Submental, submandibular, periauricular, or posterior auricular, posterior occipital. Then you go down to the anterior, to the sternocleidomastoids. You have superficial and deep, and you have anterior as well. Then you examine them so quickly, and you can always both hands. لما تعملها. With both hands and compare at the same time. Okay, so it's quite important because it might be reflected. Any lung pathology or thoracic pathology can be reflected on these lymph nodes. هاي اللي حكيناها عن موضوع الtracheal deviation. thorax inspection, inspect again for any missing findings. زي ما حكينا بعد once we finish طبعا احنا from the end of the bed بنعلق على just the environment وبنعلق على respiratory rate وعلى expansion تمام وعلى movement. Then we go to the right of the patient تمام. To the right of the patient بنعلق على skin abnormalities, normal male hair distribution or female, إذا في gynecomastia وهاي الأمور also we comment. Goiter, if it's massive, yes, you are right. You are right. يعني anything in the neck that you can يعني notice, yes, you can mention as well. Scars, زي ما حكينا زي ما حكوا زملائك إنه from the back, this is a long scar on the right, that's a long scar on the left, sorry. This is thoracotomy, open thoracotomy, or you can see the 3 notches here. So as well, there is different scars. There is sometimes bilateral but thoracic scars, subdiaphragmatic scars. وين نشوفهم بالعادة هذول؟ Bilateral subdiaphragmatic scars. Yes, excellent. عافية عليك. In transplant. Bilateral lung sequential transplantation. This is transplant. And it depends on the surgeon. محل ما كنت داوم في الأخير أجى surgeon very يعني talented صار يعملها sternotomy. صار يعمل lung transplant sternotomy. The bilateral subdiaphragmatic is called clamshell scar or clamshell procedure. Clamshell ليش؟ When they open the flap بيشوفوا كل شيء قدامهم. بيشوفوا lungs من تحت وفي base. So they can do first they remove the first lung, then they put the healthy lung and they suture it reanastomose بعدين بروحوا على اللنج الثاني. So if it's bilateral sequential بالترتيب, it's unlike the heart. The heart sometimes they leave the heart there زي الكدنيز يعني اللي في space بيعملوا orthotropic transplantation. This is just for your knowledge. Anyway, so there is a lot of scars. How they reanastomose them? It's easily because they see everything. As if you are looking كأنك بتطلع على اللنجز من تحت في space. It's clamshell. They do the incision here and incision here and they elevate. Imagine how space you have. And يعني the base of the lung and you are looking from the base of the lung and the base of the lung has the largest area. تخيلي when you remove the lung. It's easily يعني الجراح بسهولة. ليش أنا حكيت إنه الجراحين التالنتد صار يعملها ستيرنوتومي؟ لأنه السبيس is very tight في heart فهو it needs a talent إنه تعمل reanastomosis من mid line sternotomy. Anyway يعني just it's good to know about that. لا مانع. So by far any questions about inspections? Scars, deformities, dilatations, hair distribution, gynecomastia, spidernitis, everything, okay? Good. And inspection starts from the minute that you start talking with the patient, okay? Good, everything, cyanosis, start from the hands, go up there, to the neck, to the face, go down to your chest, to the system you need to examine, good? Heart, abdomen system, always. Palpation. حكينا inspection, palpation. This is the hierarchy, تمام? Palpation. Locate the apex feet first. رغم انها هي part of guarding, but it's quite important. لأنه if you have emphysema and you have a hyperinflation, the apex feet. How would you locate the apex feet? Mid-clavicular line, زي ما حكى زميلك. Then, so you come from the sternal angle. The sternal angle is at the level of second rib. بعدين you start count from the mid-clavicular line. Start counting the rib spaces. بس تصل على fifth rib space, you put your finger. Okay? You feel the beat, the apex beat. احنا زي ما احنا بنعرف الهارت, الهارت جاي هيك. انت بتقول كيف الابيكس؟ ما هي البيس. البيس of the heart اللي هي بيطلع منها البالمونري trunk والاورتا, والابيكس هي the tip of that. So we feel the apex beat. If it's displaced, يعني بدل mid-clavicular صارت anterior axillary. ممكن شو كمان؟ hyperinflation. شو كمان؟ anything that massive pleural effusion, would it displace the epic speed? And this question for your colleagues, not for you, just would it displace the mitral regurg? Would it displace the epic speed? And how? ها؟ لا خلينا في الميترال regurg. لا just let's يعني mitral regurgitation, would it affect the epic speed? My question. Which means chronically heart failure, dilatation, cardiomegaly, you're right. So this is the procedure. So mitral regurg acutely it won't displace the epic speed, but on the long run it will cause heart failure, cardiomegaly, and probably it might displace the epic speed. Okay, good. So emphysema, how the lungs? Emphysema, pleural effusion, pneumothorax, all of these might displace the epic speed and affect the site of the epic speed. Good. Right ventricular heave, or the heaves, where we palpate the heaves, parasternally, left and right. This would reflect right ventricular hypertrophy mostly due to pulmonary hypertension. So this is right, it will reflect. لأنه بصير right ventricle. By the way, what's the most anterior part of the heart? Right ventricle. What's the most posterior? Yes, excellent. بصير أقرب right ventricle مع الهايبرتروفي بصير bouncing يضرب تحت إيده. Good. Okay. Chest expansion. When you examine it, you bring both hands, you put the thumbs and the tip of the thumbs on the space. You take a fold from the subcostal, from the diaphragm, subcostal. You take a skin fold from both hands, and your thumbs should be in the air. The tip of the thumbs لازم يكونوا في الهواء, and you ask the patient to breathe. You take a good skin fold. The expansion should be normally at least what? Centimeters or 2 inches. That's true. Good. And so you comment on the symmetry and the direction, if it's symmetrical or not. If the muscle expansion are right, what do you think, for example, or the left, whatever? ممكن loss of volume, massive loss of volume. Good. Pneumothorax, pleural effusion, collapse. Good. So all of these might affect the expansion. So still we are in the exam. بعد ما طلبنا, we do not ask for investigation or imaging data. So imagine how many information you can get from history and physical exam. History and physical exam constitutes 85% of your differential diagnosis. We ask for investigations and imaging for the rest 15% to confirm or to rule out. So احنا نحكي, there is a list of differential diagnoses while you are talking with the patient. While you're examining, you start ruling in, ruling out. Another 85% اتكونت الصورة عندكم. You need another 15%. يعني very minimal situation or very few situation that still the picture is opaque, but most of the time you will know what's going on, almost, but you need some investigation imaging in order to rule in and to rule out. Okay? Paradoxical rib cage movement, Hoover's sign, which is basically onward movement in the inspiration, the hyperinflation. ليش? Due to the hyperinflation, the diaphragm زي ما حكينا is flattened. والمفروض ما يكون flattened, so it should be dome shape. Okay, so flattened. So what will happen when it's contract? It will pull the ribs inward instead of outward. زي ما حكينا في البداية, the normal. Okay, this is due to the chronic hyperinflation, either childhood asthma or emphysema. يا جماعة. Good. So Hoover's sign. Hoover's, يعني Charles Hoover's is I think I forget. Maybe he is an English doctor that he got two signs, to be honest. One respiratory sign and the other, the most important, is a neurological sign. A neurological sign in order to differentiate between functional and actual paresis in the legs. So for example, when you Google about this Hoover sign, you will find two Hoover signs. واحد in neurology, واحد respiratory. For the same, Charles Franklin Hoover. Okay. chest wall palpation, surgical emphysema. لما يصير في emphysema زي المشي على الثلج، إذا أمكم مشيتوا على الثلج it's the same. وللأمانة هي من أقل this is one of the very few conditions wherever you find the prescription in the book as if in the real life. يعني زي ما بحكي لك once as you are walking in this ice فعلا لما تحس as you are walking in the ice. So the description is very very talented للأمانة يعني. Tenderness كمان when you start palpating, you palpate for and you ask the patient always, either you are looking at his face while you are palpating or you ask him if there is any pain and you start away from the site of the pain. Then just normal palpation wherever there is a tenderness, especially لما يجوك chest pain. Okay, good. There is then Alan White, what he is doing, he is trying to locate the apex feet هنا شايف mid-clavicular, start counting the ribs, بعدين ask, if you do not feel it, you do special maneuver, you ask the patient to lean his left, تمام, in order for the apex feet to be, the apex of the heart to be nearby the chest wall عشان تحسها أكثر, sometimes for obese patient or for hyperinflated patient, and this is for what? No, this is the heaves, parasternally, for the heaves. Good. Again, what's this? A chest expansion, زي ما حكينا, posterior, interior is the same. Your fingers should be on the air, the tip of the finger, the thumbs, in the air, and you ask the patient to take full deep breath. Okay. What's this, يا جماعة؟ هذا الزلم ماله. Endofacial swelling. ممكن severe venicular accident. غيره. Huh? No, wouldn't. Nephrotic wouldn't cause this. شو كمان؟ Cushing, triad? No. This seems to be acute more. Infection of what? That's pylori. Why? شو هذا facial swelling عنده angioedema وهاي الأمور شو ممكن anaphylactic excellent anaphylactic شو كمان. And the last thing, فإذا أنتوا حكيتوا anaphylactic bee sting عنده allergy, ها؟ مش سامع علي دكتورة. pneumothorax ماله pneumothorax مش pneumothorax would be facial swelling. pneumothorax إذا صار ليك للpneumothorax subcutaneous شو بصير؟ ممكن يكون subcutaneous emphysema. Good. So يعني post surgery lobectomy for example, there is a leak. صار عنده leak and it's progressed. Patient can have progressed for another pneumothorax leak, صار عنده subcutaneous emphysema, فبتلاقي كله منفخ حتى عيونه. So good. So anaphylaxis, subcutaneous emphysema وإيش؟ superior vena cava syndrome. And often this superior vena cava إذا بدها تيجي acutely بالطريقة هاي. Okay. Any questions? We'll stop at here. Tomorrow, inshallah, the Dr. Sam will continue the discussion.